Welcome back to Ian Board Bombs. This is a friendly neighborhood episode, and we got Dr. Wasiski-Kuhn back with us.
Hello.
She just finished a grueling shift in Colorado and waited late now. It's like midnight Eastern time.
He stayed
It's
up
like
till
7 p.m.
9:30 p.m.
Feels like midnight. You know, Eastern time, what is it, like 6 hours ahead of Colorado?
Yeah. I live on mountain time.
Mountain time. Yeah.
Sounds
mountain time. Do you celebrate?
Yep.
It does sound.
You have like Eastern time, Pacific
Central.
time, and I'm just like, I don't know. We got mountain time over here.
Yeah. There's some people that live there. There's some mountains. We have to have their own time zone. What's funny is keeping track which states do daylight savings time now. Is that still a thing? It's funny.
Yeah.
Tennessee does it. I think Colorado does it too.
We do.
So,
No, Arizona doesn't though, right?
they don't do it. It's very confusing. Yes, it's Ian Board Bombs. Everyone should know us by now. Emergency medicine board bombs just blowing up in the internet, going viral. Got people coming up to me at work saying, "Hey, saw you on Instagram," and they look at me like it's kind of weird seeing me there. You know,
Right. Yes.
Same thing might happen to you, but
Yeah, it does. And they're usually like, I'm sorry that I had to give hydralysy.
it's so funny how much that's come up. Yeah. So I'll read the stem here, and we're going to let Dr. Wasiski-Kuhn answer this after a grueling shift. She saw a lot of children today, so maybe this came up.
It's
We
true.
have a 6-year-old boy dressed up as Superman falling from a swing. Pretty ironic. And he struck his head on the mulch. There was no loss of consciousness, according to the mother who was there, and he cried immediately, vomited once, and now complains of a mild headache. His GCS is 15, his vitals are normal, and the neuroexam is non-focal. He's using both his hands to do things, and he's ambulatory in the room. The patient is telling you he is very disappointed he can't fly in his costume. What is the best next step? Choice A, CT head without contrast. Choice B, observation in the ED for minimum 3 hours. Choice C, MRI brain. Choice D, discharge home immediately. Dr. Wasiski-Kuhn, what's the correct answer?
All right. So the patient can walk, but he can't fly. So the answer here is going to be B, observation in the emergency department.
Bingo. And there may be a few disappointing people out there who thought it may have been, I don't think anyone was going for the CT head here. Obviously, they know where this question is going. You shouldn't be CTing kids on average for falls, but maybe some people thought discharge home immediately, but we'll talk about why that wasn't the correct answer in that case. But first, we have to obviously talk about what?
EM rapid bombs?
Of course, EM Rapid Bombs, yes. EM Rapid Bombs, the only board question podcast out there. Can you summarize it any quicker than I can?
Not as quick as an episode of EM Rapid Bombs can deliver some amazing high-yield hits to prepare you for your board exams, your in-training exams, your shifts every day. It's quick, 3, 4, 5-minute episodes delivered straight to whatever your favorite streaming service is. It's not a question bank. You don't have to stare at a computer screen. You just listen to it.
I saw a resident yesterday, emergency medicine resident, log on during some downtime in the ER yesterday. He pulled up an undisclosed question bank who shall remain nameless. And let me just tell you, it was pretty awful. It was not fun, and he looked pretty miserable doing it. And there was a tear streaking down his cheek because he looked depressed doing it and clicking through the answers. So I really do believe that our question bank brings joy to people's hearts. So check it out.
I know.
Check it out. Over 550 questions now? Insane.
Yeah, so many.
Yes.
And I have friends right now who are studying for their board exam, and they were like, it's crunch time. I can't do crunch time with question banks. You can do crunch time with EM rapid bombs.
There we go. Just crush it. Crush it. Hey, so this is a sweet spot for applying what in this child?
PECARN.
Oh, yeah. That's been out for years now. Isn't that crazy?
Yeah, so PECARN, there's a bunch of PECARN rules, but this is the one that everyone knows the best. I think it's been around the longest.
Definitely.
The Pediatric Emergency Care Applied Research Network. So they come up with a bunch of really useful rules for pediatric emergency care. And this is the one for minor head trauma. So for children over 2 years, that's what we're going to be talking about today. This kid in the question stem was 6. So remember that. So GCS greater than 15 was this kid. So if your GCS is less than 15, you're going to CT that kid. If you've got signs of a basilar skull fracture, I would hope You're going to CT that kid if they've got CSF pouring out of their ear, battle sign. It's just like, please, you shouldn't have to think about PECARN to know you need to
Yes,
CT that
very
kid.
obvious.
If they're really altered, again, GCS less than 15, or if they're just very altered, CT the kid. If none of those are present, you can ask about intermediate risk findings. So again, these are things that I think you would probably ask about anyway, but if not, just remind yourself about PECARN, pull up MD Calc or whatever it is that you use for reference. History of loss of consciousness, vomiting, ask how many times they vomited. We'll get to why that's important in a minute. Do they have a severe headache? Not just like, oh, you have a bruise here. I'm going to push on it. Did that hurt? Oh, it's like a headache. Do they have a severe headache? And then was there a severe mechanism? You can look on PECARN references themselves to see what the actual severe mechanisms are. I think the one that I find myself thinking about the most is what height a fall is from. For a kid over 2, it's a fall from a height greater than 5 feet. Or if there's like a very high impact motor vehicle accident, if they were in a bike accident without a helmet on. But again, like a fall greater than 5 feet. So this isn't like, oh, I fell out of a chair or I fell over from standing.
Definitely.
So yeah, if any of those intermediate risk findings are present, observation for 4 to 6 hours is recommended.
Definitely. And then you're going to CT if any worsening symptoms, like they continue vomiting or if they have any change in mental status, really is the main thing. Some people are going to ask, they're listening to this podcast, mostly newer learners, which is great. They're going to say, how do you do a GCS or how do you do any mental status exam on a newborn? Or how do you do a mental status exam on a 2-year-old? What would you say to that?
I'm actually thinking about the episode we did on PALS when we were talking about
Yeah.
the GCS.
Yeah, that was a good one.
Yeah, when we were talking about infant GCS and if, how consolable they are.
Yeah.
But yeah, I mean, a kid that's 6 years old should know their name and probably know the day of the week. You can really judge those things. They should know how to give you a thumbs up or a high five. A GCS is really not that different in a kid that's 4 or 5 years old. Once you get to a kid that's under 2, there actually is a different GCS tool that you can use about how consolable they are.
Yes.
But it's not that different for a 5-year-old or a 4-year-old than it is for a 40-year-old.
Yeah, very unpopular opinion here. This might be like the hydralazine take we did. I hate the GCS. I think the GCS is like one of the most overrated things ever. So if you're listening to this and you're like, I don't want to calculate the GCS, don't worry about it. Just do a mental status exam on these patients. And if they're altered, meaning if they're less than 15, then you're done. Like,
yeah,
you're going to CT them. But it is, oh my gosh, it is so obnoxious for me when in the trauma bay, this is a completely different situation now, we're going on a soapbox, when the poor little intern at the head of bed or the trauma resident in the room, the chief resident's being questioned by their attending, like, what GCS do they have? Everyone knows we're making this up. Everyone knows that this is going to be like 1 to 2 points off. The answer is, are they open their eyes? Are they talking? Are they all, the basic questions. But the problem is there's so much guesswork involved with the GCS. Anyway.
Well, it's just the whole, a dead person can have a GCS of 5 situation. Their eyes are open.
Exactly right. Anyway, let's go through the answer choice why they're wrong here. Let's focus on the children. We do it for the kids.
Yeah. Do it for the kids.
Choice A, CT head was wrong. Unnecessary radiation risk. I can't tell you the number of times on boards they're going to tell you not to CT kids. And that's probably the right answer, right? We should train ourselves not to CT kids. There are so many times I've had children come in and to the ER and the parents are like, yeah, we've had a CT in the past for this. I'm like, whoa, that's aggressive.
Yes, I totally agree. And I find myself telling parents this often because I feel like I have to justify myself because parents,
isn't that crazy?
Parents want a CT a lot of the time. Yeah, and I have to be like, you know what you don't want? Lymphoma.
Cancer. And the lifetime malignancy rate is, more and more studies are coming out. This is a big deal, a bigger deal than we even once thought. And some people dismiss this, that it's very, not causative, but I feel like it's pretty causative considering the medical industry is like the number one source of radiation for any other American, you know what I mean? So anyway, the CT risk is like 1 in 1,000 here in terms of malignancy association. That is quite a bit. That is quite high.
Yes,
Yes.
it's a child. You're not
Yes.
radiating an 85-year-old. It's a
Yes.
child. They
Totally
have a
different.
ton of developing lymph tissue right here.
Yes. Right there. For those of you not on the YouTubes or the Instagrams, she's
Yeah,
pointing to her neck.
I'm
So
grabbing my neck.
choice C is MRI. Obviously not reliable here. Who can even get this on the average pediatric ED or average community ED? So we're not doing that. It's obviously the wrong answer. Choice D is immediate discharge. Now, some of you out there might have done this. Maybe you're thinking, oh, I've done that in the past. Well, don't worry about it if you did it earlier today. They'll probably be okay. Hopefully they'll come back. Anyway, so inadequate monitoring is the big thing here. This childhood vomiting, which Dr. Wasiski-Kuhn just went over here, that although isolated, does place this patient in the observation tier. So the pro tip here, which I've done in my own practice too, is making sure your kiddo can tolerate PO during the monitoring period. Perfect opportunity to entice them with a popsicle
Mhm.
or a Jello or a juice cup or something like that. Nothing worse than an immediate repeat visit for vomiting. And they come right back and they're like, oh my gosh, we should have done the CT to begin with. And you got to recover all those lost brownie points you just lost. So
Yeah.
anyway, why don't you go over the deep clinical pearls here, deep dive,
Yeah,
and then we'll wrap this up
definitely.
here.
Yeah, so I think I mentioned this earlier. PECARN's not a rule to memorize. It's a framework for shared decision making. This is another one of those little talks that I love to just have with the parents immediately. It's a huge emergency medicine network of a bunch of pediatricians that have gathered a ton of data, and we know really well how to make these decisions for kids so we can do what's best for them and avoid unnecessary radiation. And there's near 100% sensitivity for clinically important TBI. And if you need to, review it really quickly before you go in the room, go ahead and do that. But the history gathering is pretty straightforward. Remember that isolated vomiting is not an automatic CT
No, this is
trigger.
big.
Yeah, you'll see it often, but it is not an automatic CT trigger. In PECARN validation, risk of clinically important TBI with isolated vomiting is less than 0.3%. Okay.
Say
But
that again, louder in the back,
yeah,
louder in the back.
yes, in validation, risk of clinically important TBI with isolated vomiting less than 0.3%. That's small.
That's crazy.
Yeah. Observation and active management, do serial neurochecks, reassess for worsening headache, repeated vomiting, change in mental status. Remember, actually come back in the room more than once. Don't just like put them in your ED for 4 hours and see them at the time of discharge. That's not cool. You want to
Right.
actually do at least a couple repeat exams on the patient, even if it's just like walking in the room for a minute, asking them how their popsicle was and how they're feeling. If they're
Sir, would you like another one or can we give you the bill?
If they're under 2 years old, remember that altered mental status and not acting normally per the parent. Remember, you don't know the kid. You can't just decide what's acting normally for them. You got to ask the parents. Those are high risk triggers. Non-frontal scalp hematomas greater than 3 centimeters are CT considerations. Kids land on the front of their head all the time. Remember, toddlers toddle, they land face forward, so they have a really thick skull in the front. So they're
Definitely the safest part of the skull, and that's why
meant
it's
to
there.
land there. Yeah. And I remind parents of that all the time. They're meant to land on the front of their face.
Yes.
Beware the well-appearing concussion. 20% of kids with concussion have a normal neuro exam. Symptoms are going to evolve over an hours. Um, give give parents
So I'm
good.
just thinking of the average parent and or individual that comes in and like you go over all their scans are negative, and then everybody just looks and you're like, so there's no concussion.
Oh my God. Yeah. 100%. Or they
So
describe like the most classic concussion ever. And they're like, we're just here to find out if they have a concussion. And you're like,
I'm
yes,
like, well, I got news for you.
you just told me they did.
Yes,
Which a great chance for education about what a concussion is, concussion
absolutely.
precautions. I don't like the pre-canned discharge instructions for concussion. I have my own.
Yeah, they always suck everywhere.
They're so bad.
They're so bad. They're like 10 years behind.
Yeah.
I
Yes.
think
My
ours at
God.
ours place they like grade it mild to severe. I'm like, we don't do that anymore.
Yeah. It's terrible. And they're like, put your child in a dark basement for the next 3 years. Oh
Yeah,
my God. No.
no sunlight. Don't even think about kicking that ball outside.
They'll never play sports again. And I have a special one just for like infants as well, because
Oh,
you're not
good.
going to give the same concussion precautions to an infant as you are to a 6-year
Yeah.
old. It's going to be a little different.
Okay.
And remember, for for all kids, no same day return to play. So, well, you don't need to lock them in a basement. You're not going to tell them that they can go back to football practice
Totally.
immediately, please.
Totally.
They do need early cognitive rest for at least 24 hours, probably 48, knowing most kids, but then they can gradually return to school and activity. They got to screen for red flag symptoms, severe worsening headache, repeat vomiting, any kind of focal deficit seizure. They
Yeah,
should come back. I always tell parents, I hope if your kid ever just has a seizure, you would bring them back to the ER if they've never had a seizure and they have a
definitely.
seizure. And then you're not the one that should clear these kids to go back to
No,
play.
never.
Don't do that. That's
Don't do
not
that. Don't
appropriate
do
for you
that.
to do.
No,
And so tell them that they need to follow up.
totally. Hey, let's wrap all this up in a nice little bow and let's do some coaching, just like we do in the rapid bombs, where we summarize everything we just said, tell you what the test is going to ask, and then what in real life you're going to do. So why don't you summarize 5 key points here and for our folks on socials?
Yeah, I wish I could do the whistle sound.
What?
You know the whistle sound like they have on like we do on
Oh, the
rapid
coaching
bombs.
whistle. I was like,
Yeah,
what?
the whistle sound.
I thought it was some pop culture reference that I failed to get, as usual.
It's so
Yeah.
late for Dr. Briggs. Oh my gosh, you
Yes.
guys.
Yeah,
Give
it's
him a
like
break.
midnight. Midnight on the next day, actually. So we're like more than 24 hours ahead of you. It's crazy. Circled the globe twice. We're ahead of you.
All right.
Go ahead. 5 points.
5 points on pediatric head trauma. So, 1, PECARN separates kids into 3 buckets: CT, observe, immediate discharge. 2, isolated vomiting or mild headache, observe. 3, radiation risk is not trivial. Avoid doing a reflex CT. Don't order that unless you have seen the patient and evaluated them.
I feel like it should
4,
never be a phrase, reflex CT.
4, observation is safe when GCS is 15 and you have a normal neuro exam. And 5, never clear concussion for play in the ED.
Bingo. Bingo.
Hey, Dr. Briggs.
Yep.
Hey. Are you feeling
Hello.
awake right now?
I'm slowly awake. I drank some coffee earlier.
I love that.
Yes.
How do you feel about doing a shorts review on pediatric head trauma for us?
Perfect. Perfect. As long as we're not doing reflexes.
No.
I had an intern the other day ask me, it was like during a code stroke evaluation. It was like their first code stroke evaluation ever. And this poor intern was like, I did the whole neuro exam and showed him, this is how you do a rapid neuro exam. And I finished up and the intern was like, so you didn't do reflexes? And I said, we don't do that here.
You were like, well, because the brain doesn't participate in the reflex arc.
Yeah, exactly.
And this
Exactly.
is a stroke.
I think he was disappointed in a reflex hammer. All right, cool. So shorts here. Let's cover this. Key points. Under 2 years old, PECARN, you're CTing these patients if they have altered mental status. And by that, that means that, of course, parent in the room should definitely tell you how they're behaving. You know, not awakening, not regarding caregiver, no appropriate age behavior. That's very concerning. The palpable skull fracture, of course, that's concerning. And then delayed recovery from loss of consciousness and severe mechanism. Greater than 2 years old, greater than equal to 2 years old, I should say, you're doing CT only if they're altered or have a basilar skull fracture or GCS less than 15. You're going to observe the vast majority of these patients. Isolated vomiting, not indication for CT. Less than 1% of the time, less than 0.5% of the time, how about that, is associated with a significant head injury. You're going to observe them if they have any 2 points of headache or if they have a minor mechanism. The vast majority of patients are going to be observed. And you're going to avoid CT in the vast majority of children with a single low-risk feature. And the big thing is counseling parents. We talk about this, how you counsel them. You mentioned PECARN, mention how big of a database it is, thousands of children, multiple different hospitals. Been doing this for years. This is big, and a big thing we can reduce our CT utilization on. So on the boards in real life, this is one of those test questions that's like the same as the real life answer, which is don't do CTs on these kids. On the boards, you will flunk if you do this on your oral boards case.
Yeah.
All right, cool. We'll see you next time.